So the next topic is regional anesthesia for eye surgery. What is newer and safer? I know that regional anesthesia is more done by the ophthalmologist than the anesthetist. But as an anesthetist, we have more knowledge about the drugs and other newer procedures. So that's why this topic is for an anesthesiologist who is working in a tertiary ophthalmic anesthesia center, that is RP Center AIMS. Dr. Arshad, over to you.
A very good morning to all.
So,
मुझे भी change करना है. Good morning all. Myself Dr. Arshad Ayub. I am from AIMS New Delhi. I am here to talk about regional anesthesia in ophthalmology. What's new we are planning to do and what's new we are doing now. So initially when I joined in the RP center around 7 years back, my perception was ophthalmology is all about the cataracts, which is a short procedure, which is ambulatory, which has got minimal pain and can be done under topical anesthesia or the peribulbar anesthesia. Then I got a shock that no, this is not. It is for the neurofibroma for orbitotomy, which is orbital tumors. This is for DCR. This is for syndromic, for the major repair, for the burn trauma of the patient, for the graft from the post-auricular graft or the intra-auricular. And these cannot be done without with a simple peribulbar block or a topical block. So what was the solution to us? The solution was we started using and trying to use the ultrasound guided regional blocks. For those who are the ophthalmologists here, this might be a new thing to you. So I would like to inform in a very brief about what is ultrasound and how do we use it. So ultrasound is basically constitutes of a transducer which have piezoelectric crystals, which when stimulated gets vibrated and produces the sound waves. These sound waves go and hit our target structure, and then these sound waves are reflected back to the transducers, and then these transducers project these images on a screen to get an image. For example, if we are scanning the kidney, we are putting a transducer and we are scanning the kidney. So sound waves are emerging from the probe and getting reflected back to the probe from the kidney, and we are getting an image. So ultrasound waves are there, then they are reflected sound waves, and then these reflected sound waves are perceived by the probe to prepare and process an image. So there are two important things in that. Number one, transducer, and number two, the tissue, and we also call in terms of tissue ecogenicity. So what is the ecogenicity of the tissue? So there are three types of transducers. We have linear and we have curvilinear probes. In linear, we have small probes and we have a larger probe. And in a curvilinear probe, we have a high frequency probe which has increased penetration and can be used for the ocular ultrasound. For ecogenicity of the tissue, it depends upon tissue to tissue. For example, the bone would look like a hyperechoic structure. A white line, a continuous hyperechoic structure would be a bone through which no sound wave can pass. So this is what it will look like. Then there is the muscle. Then there is a vessel which would look anechoic. That is completely black. And the muscle has got fibrous strands and the collagen, and then they would look like something like this. And then we have the fascia, which encloses and it looks hyperechoic, but the sound wave may pass through it. So remember, the bone is a completely hyperechoic structure through which no sound wave can pass. Now, when we know this thing, there are two types of needling approaches. One via called in-plane approach, one via called out-of-plane approach. When we go out of the plane, we can only see a point of intersection of the needle which is coming on the path of the sound waves. So you might be able to look only indentations or a point of the needle. Or if you're going in plane approach, then you will be able to see the whole length of that. We will come across with these type of techniques soon in next presentation. So after this, what are the nerve blocks that we are going to discuss here? We are going to discuss infraorbital, supraorbital, mental nerve block for the lip grafts, and zygomatic-temporal for the lateral part of the eye. And sometimes we have to take grafts from the posterior part of the ear, and which include lesser occipital or the greater auricular nerves, which are the part of the cervical plexus for the grafting. So let's jump to the regional and start what we are doing and how we are doing. To understand this, we have to understand the anatomy. We have to understand how to scan, how to know what does after scanning it will look like, and how to give the injections. So we'll be covering all this part on these 3 parts. Now let's jump onto the anatomy. That's what I was saying. I need to change. स्लाइड में नहीं है भाई, अलग से एक अलग पेज है. इंटरनेट नहीं भाई, ये ऑफलाइन है. स्क्रीन में डिस्प्ले होना चाहिए ना. So let's start with the anatomy. So we were talking about so we will talk about the supraorbital nerve, infraorbital nerve, zygomatic-temporal nerve, or the mental nerve. So supraorbital nerve, here you can say, is a branch of the ophthalmic division of the trigeminal nerve. This is the supraorbital nerve. Here the supraorbital nerve lies on the surface of a ridge or arises from a foramen called supraorbital foramen. Infraorbital nerve arises from a foramen called infraorbital foramen. Zygomatic-temporal nerve is on the lateral part of the temporal bone on the posterior orbital lip, just here. So this is the zygomatic-temporal nerve. Okay, so zygomatic-temporal nerve, if want to block, we got to hit the posterior lip of the lateral orbital rim, and then there is a mental nerve. Mental nerve is arising from a mental foramen which is just on the mandible. So how do we scan this? First of all, we keep a probe for supraorbital nerve. We keep the probe in a transverse view over the surface of on the forehead of the patient, and then we move down. As soon as when we keep it on the forehead of the patient, we should be able to see a bone. Bone should look like a hyperechoic white line. And as soon as we go down, we will see a breach in the continuity of that hyperechoic line. That breach should be sufficient enough to inform us that there is a lacuna in the bone there, and that lacuna is most probably because of the supraorbital foramen or the ridge. Similarly, with the infraorbital, we will start from the down below, and we will move the probe up. As soon as we will move the probe up, we should be able to see a breach in the continuity of the bone, and should be able to see the infraorbital nerve. And for the zygomatic-temporal nerve, we will keep our probe on the zygomatic process, and this will look like a white hyperechoic line. As soon as we will move up, we should be able to see the loss of this continuity of the bone, and only see a medial side of a part of the bone, and on the lateral part of it, we will deposit the drug, and we will be able to block the zygomatic-temporal nerve. For the mental nerve, we will keep the probe on the mandibular, and then we will move up. As soon as we will move up, there will again a breach in the continuity of the bone, and we should be able to see the mental foramen. These nerves are very small and may or might not be visible to the naked eye, or even in the ultrasound. Now, for the graft, we have two nerves. First is greater auricular nerve. It supplies the anterior part of the ear. If you want a graft from the anterior part of the ear, from the tragus, we have to block the greater auricular nerve. Then we have this nerve. This is the lesser occipital nerve. It supplies the posterior part of the ear. So if you want to take a posterior auricular graft, you have to block a lesser occipital nerve. But there is a simple thing to that. These both nerves are the part of the cervical plexus. So these are the cervical plexus. So these are, all three nerves are the part of the cervical plexus, and these are lying inside this muscle called sternocleidomastoid and lying on the surface of perivertebral prevertebral muscles. So on the surface of the prevertebral muscles, we should be able to see the cervical plexus. These nerves are branch of the cervical plexus, and just on the lateral side of these two great vessels called the carotid and IJV. So at the level where the carotid is dividing into two parts, at this part we should be able to deposit the drug below sternocleidomastoid muscle above the prevertebral muscles, and we should be able to block the cervical plexus, and hence both greater auricular and the lesser occipital nerves. So once we know the anatomy, let's jump onto the blocks and the interesting part. It's not moving. Next slide.
Dr. Arshad, you have 2 minutes left.
Fine, ma'am. So coming on to the first, supraorbital nerve. Here we are keeping the probe on the forehead of the patient and going toward the supraorbital ridge. So what are we going to see? We are going to see a continuous white hyperechoic line, and when there will be a breach in the continuity of the hyperechoic line, that means this should be our supraorbital foramen. So this is the real-time scanning video of it. Here you can see we started with a hyperechoic line, and then we see a breach in the continuity of the line. So this is the supraorbital foramen. You can also see there are some vessels up there in the color mode. This shows that there are supraorbital artery and nerves up there. So we should always be safer to look out for the artery. This is one of the injection which is the outer plane, so you won't be able to see the whole length of it. You will be able to see some indentation and some drug deposition there. So after the supraorbital nerve, we have infraorbital nerve. We are again placing the probe below the infraorbital ridge, and then moving upwards, and you will see there is a continuous hyperechoic line, and then there is a breach in the continuity of the line. In this, you can also see a black anoic shadow. This is infraorbital artery. So if you can see in the scan, this is a white hyperechoic line, and then there is a breach. And in this, you can appreciate an artery there. This is infraorbital artery. The nerves are very small and difficult to visualize. This is the injection on it. If you can appreciate the indentation on the infraorbital foramen. So this is how we block the infraorbital nerve. Then there comes the mental nerve. Again, we are placing the probe on the mandible of the patient and then moving upwards. Again, a white hyperechoic line, and then there's a breach in the continuity of the continuity of the line. This proves that this is a mental foramen. So this is one of the videos of the scanning. This is white hyperechoic line, and you can appreciate that there is a breach in the continuity of it. So this is mental foramen. This is the injection video of it. You can see this some indentation happening there. I don't think it is very well much appreciated, but there's some drug deposition in the breach in the mental foramen. Next, we have zygomaticotemporal nerve. Zygomatic-temporal nerve, we put the probe on the zygomatic arch, which should look like a white hyperechoic line. And as soon as we to move up, the lateral part of the zygomatic arch or the white hyperechoic line will stop being visible, and only the medial part of it will be visible. So you will start with the zygomatic arch, keep the probe on the zygomatic arch, and then we will move up. Keep the probe on the zygomatic arch and move up. So what you will see? You will see a white hyperechoic line, and then suddenly the white hyperechoic line will stop to coming, and you will see a just posterior orbital rim, and we will deposit the drug on the posterior orbital rim of this patient, and should be able to block the zygomatic-temporal nerve. So this is a real-time in-plane approach where you should be able to see the complete length of it. So this is the orbital rim, and you can see a needle coming from the lateral side and depositing the drug on the lateral orbital rim. So this is how we block the zygomatic-temporal nerve. Lastly, it is the greater auricular and the posterior occipital nerve or the cervical plexus nerve. So we are putting the probe in a transverse view over the carotid, and then moving up to get to the point where we are able to see the division of the carotid artery into external and internal branch. So first of all, we have to look into this muscle, sternocleidomastoid.
Dr. Arshad, I think we will be not able to spare more time because there is another session after this.
Just 4 slides, ma'am. I just left with the 4 slides. So this is sternocleidomastoid. Then we have perivertebral muscles up there, and then we deposit a drug. You can see on this part of the carotid. This is the carotid dividing into 2 parts, and as we go laterally, you can see these 3 nerves. These are part of the cervical plexus. So what about the peribulbar? Is there any role of ultrasound in this? Ultrasound for peribulbar block is still in infancy, and it is not much recommended. Why? Because it presses the globe and decreases the space. Number 2, real-time injection is very,
I am
very
sorry,
very
Dr. Arshad. It's 15 minutes, more than 15 minutes. So if we will have time, we will continue with your talk afterwards.
Then just 2 slides are left. This is the second last slide.
Okay.
But there's a session to follow you, right?
Just 2 slides left.
But there's still a session to follow you.
Shall I stop it now?
Yes.
Fine, thank you.
Thank you, Dr. Arshad.